Good evening. Welcome, everyone. We appreciate you joining us for our monthly installment of our Mastery Surgeon webinar. And tonight is a really exciting event here. We are excited to introduce the launch of the newest implant system here at Treace, the SpeedTMT Implant system with precision, strength, compression, and speed. So once again, we appreciate you being with us this evening for a very exciting topic that we're bringing to you this evening. If you are new to one of our webinars, a few housekeeping and logistics items. All attendees upon joining are automatically placed upon mute, but we really enjoy for these to be interactive. So at the panel, at the top of your screen or at the right-hand side, depending on your formatting, there's an area where you can type in to a chat or comments, questions area, any comments or questions you have. We will be monitoring these and asking them throughout the evening, and then we'll have some time at the end of the program to hit anything that we may not have had time to address at the moment or any residual questions. So without further ado, on to the main event. I would like to turn it over to our very esteemed faculty for this evening. Our moderator is Dr. William DeCarbo out of Pittsburgh, Pennsylvania. And then our panelists and faculty for this evening are Dr. Chokan and Dr. Justin Dagg, who is a little bit delayed. He'll be joining us later on, but thank you for being here. Dr. Chokan, thank you, and Dr. Dagg here in a little bit. And I'll turn it over to you, Dr. DeCarbo.
All right, well, thank you all for being here tonight and spending this time with us. As Lauren said, we're super excited to introduce the SpeedTMT plate. This is going to be an introduction to an advancement in our triplane correction and biplanar plating. So I will serve as moderator. Dr. Chokan, I'm basically his best friend. He's on this call as well. And Dr. Dagg, when he's done healing sick folk, he will be on. We are paid consultants. You know, the overall thesis of Treace and Lapiplasty has been this is a three-dimensional pathology and we need a triplane solution. And that's what Treace has created through Lapiplasty, and that has developed other techniques that you know about. We pride ourselves on instrumented, reproducible, and consistency. And it's really that frontal plane that's the key. You know, Aaron, before Lapiplasty, what was your go-to procedure for bunion?
Yeah, I was Austin all the way, or I'd even do closing base wedge osteotomies back in the day.
Yeah, and one of the things that we've found over time, you know, we do those biplanar osteotomies, we can't really address the frontal plane. And so that really was the key to everything. This picture, the clinical and the radiographic, kind of shows the magic of the Treace system. When you have instrumentation, you can dial in the correction and get that triplane deformity corrected out. And we're looking at the transverse, sagittal, and frontal plane. So, you know, Aaron, every time I do these cases, still get excited to see this. I mean, you're seeing complete anatomic reduction of that first ray.
I even did a lab last night that just was able to watch it, and sometimes you can even see the great toe shift back immediately if you've done your release properly. But yeah, to me, I've always done this or wanted to do this because I always missed it by that much when I did straight Lapidus. I always felt like it was just slightly undercorrected. Now I can walk in and do this every single time and get the same reproducibility with this every time.
Yep, absolutely. So that instrumentation and that reproducibility, again, is the thesis behind Treace, and that is really the magic. That is the why, and that's so important. With that said, once we get into this corrected position, we have to fixate it, and we believe that we have best-in-class fixation. You know, traditionally, we have the plate and screws, which are very good, but we've developed something called SpeedPlate. And the SpeedPlate gives a continuous compression. And the idea was the tines serve as the screws. So instead of putting on a plate with 4 screws, all screws and plate go in at once. And this SpeedPlate, when this came out, how did that change your practice? Did you adopt this right away? Are you a speed plate user at this point? How do you feel about this?
Yeah, so when I first started, all I could use was 2 plates and a screw from a completely different company. Just just 2 plates and a blade. And this came out and was truly revolutionary for me because, I mean, just to be able to, sure, you can put a quote unquote staple in, but these are, full titanium. Honestly, never seen one break. I mean, we even do studies have shown how amazing this speed plate can actually rapidly compress. But I mean, literally, you could see the bone just compress right on the table when you place it in there. And again, it's just the speed. I mean, it's quickly 2 drills, check on X-ray, that's it. Let it go. So to me, it's been revolutionary for practice in many regards, not just Lapiplasty. Other fusion sites as well.
Yeah, that's a great point. The idea of this was, can you put in the 4 components with the screws and the plate all at once? And then we wanted to test that, and we made this load to failure and cycle to failure, and it actually outperforms our S4A plating system. So there's tremendous strength. The micro Lapiplasty was kind of the real genesis to the speed plate. And the reason is we needed a way to get in fixation that had the same structural integrity of the plate through a small incision. And because it was so small to fit the screws in, that became problematic. As that continued to evolve, we developed a FirstMTP dorsal fusion plate, which is the SpeedMTP plate. And what was added to this was off-axis bicortical locking screws. And the results of this has just been fantastic. We published this for the first time at ACFAS this past year. And we believe that a couple of things are happening. One, you have an additional point of fixation on either side of the fusion site. You have an out of plane fixation other than the tine, so it's out of plane. And then third, it's compressing that plate down to the bone. So as you release that, you're not getting any potential migration dorsally. So you're getting complete compression. So Aaron, this plate came out, FirstMTP Fusion. Talk to us about your experience in regards to adding those screws to the speed plate.
Yeah, so what I was just thinking is how long it would actually take you to put one of those regular plates on, when you do your lag screw and your plate. I just was thinking back that you got the drill, you have your variable angle, if you will, or you got the locking guides, you got to screw it in, you got to drill, you got to measure. I mean, this is one of those things where you literally apply it, find the spot that you need it. You're across the joint because you have that, the guide that shows it, and then literally drill, place the 4 prongs in there, and then at that point, knowing that you can actually throw these off-axis screws has been really quite something, because you can really just know that you're getting that full compression. You don't even have to think about like measuring. You can kind of look at it and kind of go, all right, it's first metatarsal. I know that's going to be a little bit longer than the phalanx, but I mean, it's just one of those things where you know that you're at least going to get these thrown in there, and they don't have to be bicortical either, because they're just locking screws. So for me, it's been a game changer really when it comes to first MP joint fusions.
Yeah, and what we were seeing is you have an X-ray and you're 7 days, 7 weeks, or 7 months, and those X-rays all look the same. We know that bone is trabeculating over time, but with this additional construct, we really saw a complete obliteration through the fusion site. And that's something that we're really excited about, and we watched it. And that's one of the genesis towards the SpeedTMT, taking that technology and extrapolating it proximal. But there's other reasons for this as well. With the biplanar plating, this is a couple of studies that there are patients that tend to have a higher rate of recurrence or a higher rate of potential non-union. And what that really has bared out to be a lot of times is a male patient. So this is a study on FirstMTP fusion with biplanar plating, and the male complication rate was 71% compared to females, and FirstMTP, upwards of 17.5% versus 3.8 with females. So Aaron, in your practice, Are you seeing this differentiation? Are you noticing a difference in male versus female patients?
Yeah, I mean, if we're talking about first TMT, I have already, even if I'm looking at the old speed plates we had, now that we have the newer product that we're talking about, but before I literally would add 2 or 3 more screws because I felt like it was just not enough to grab onto such a large bone, especially for a guy, I mean, that's a big metatarsal base. So number one, I've seen it happen in my practice where I've actually had to throw an intercuneiform screw, then I'm doing M1C2. I'm even actually sometimes doing a screw directly down, the first metatarsal of the cuneiform, like an interfrag screw. And I've even seen it happen on a male first MPJ where I actually used 2 duals at the time, and I literally had to go back. I mean, I recently just saw this guy 2-3 months, maybe a month ago. He's 3 months out and took a bone graft from his heel and then used the SpeedTMT across it, and he's fused beautifully now. It's just crazy how those 2 speed plates at the time didn't hold it, but this robust plate has made him fuse fast. So I've seen it personally.
Yeah, absolutely. And I think that there's there's multiple things, obviously there's larger, foot that may be creating a larger lever arm and more strain and pressure through these fusion sites. There may be a compliance issue, frankly, sometimes, guys just do what they do and you can't really slow them down. So with all that said, and with the success of the SpeedMTP, with the addition of these 2 off-axis bicortical locking screws that go through the plate, we're super excited to introduce the SpeedTMT. So it's that same technology. It's blending the speed plate with our traditional S4A, S2, S1 plating system and getting that combination of plates and screws. And this is really a streamlined fixation. It's designed to not create tissue irritation, so the edges are rounded off, and we'll show that here in a minute. It's low profile, and this is a great addition to our biplanar plating. When we get into cases, Aaron will talk further in regards to this. The dimensions of the plate at its ends, it's 7.5 millimeters. In the center, it's 5.7, and it's still creating that aesthetic look where we can see the joint. So Aaron, we talked about that biplanar plating. Initially, we can see the joint. We want to see that fusion. We want to see the trabeculation. When SpeedMTP came out, that same narrow, sleek plate, so we can see the fusion site. And now with SpeedTMT, the center portion is anatomically thinner than the ends. Do you feel that that is a benefit in seeing that tarsal metatarsal?
Oh, for sure. When you had regular the plating, you could sort of miss whether or not you've caught, all the areas that are within the intermetatarsal space, or maybe you felt like there was, sometimes you could see, like looking straight down, you may miss, or it may look like you've kind of gapped there. But now with this, I can see the entire joint surface. I can kind of get across it to be able to see the medial lateral sides of it and not feel like I'm missing one part of it, do not feel like it's fused completely.
Yeah, absolutely. And that's something that we wanted to continue to watch, that trabeculation and watch the healing of that bone. The length of this plate is 36 millimeters. The inner tines are 17 millimeters, as you can see, and the outer tines are 14 millimeters. In between the tines, you have almost 14 millimeters. And that's important because if you do revision cases or you use bone grafting with this, you have that option. So, a lot of times, Aaron, what would you say if you were doing a revision TMT and you wanted to lengthen that medial column? What's your average, bone graft width in that area?
Yeah, I mean, based upon how much you have to take, of course, it could be, anywhere between a 9 millimeter to sometimes a centimeter wedge if you have to,
Yeah, absolutely. And so
a
this
large
is
piece.
designed specifically at 14 to span that gap. The screw sizes are 12, 14, and 16. And the reason for that is really that dorsal lateral area the screws will bite inferior and lateral, and we don't want that impeding into the intercuneiform, joint if you don't want that to be. Again, low profile, 1.35 millimeters of thickness, and then you have that kind of Porsche-fied rounded edges. So, Aaron, there's a rumor you were the first in the country to ever put this in. Any tissue irritation, any bulkiness, how did this compare to your previous, fixation, whether that be S4A or speed plate in and of itself?
Yeah, now that we're able to kind of feather rasp it down to give a little bit more space, for when I'm doing my Lapiplasties, I really don't like a step off if I can avoid it. So I really try to get that joint to be completely congruous if I can. If there's happen to be a step off, that's fine. Now we can kind of knock down that whole medial cuneiform. But I've seen this have, I don't want to say it's less bulk. It definitely feels less bulky. My first patient, I think I put it on, was probably a 17-year-old female. So what's funny is that, which is great comparison, because her other foot, she really did not like the hardware. It was rubbing, kind of irritated her. I think those were a different plate, but we took those out, and then we went on and did this one. And so far, 6 months out, doesn't feel it, doesn't get bothered by it, is very happy so far. So, I mean, it's kind of just a great difference to show that she really doesn't notice that that's in there. So for me, streamline, the curve is great. You always want to flatten the bones out, but from my standpoint, I've seen that it actually really binds down to the bone. It doesn't have that arc that feels like it's really sticking up. You've seen some quads that almost look like it's not teetering, but not quite on the bone. This really sits really nice on the first metatarsal and the cuneiform.
Yeah, I completely agree. I agree 100% with the feather rasp. I also think that addition of those locking screws into the plate really sucks that down. We saw that at the first MTP, and so far we're seeing that at the first TMT with SpeedTMT, and that's just been a game changer in regards to this fixation option. The reusable items are the drill guide and then the inserter cap. A little bit different on the inserter cap, and we'll talk about that here in a minute. And then the drill guide, it's similar to the SpeedMTP. And we'll show you both of these in action here in just a minute. When we look at the biplanar plating, we're still trying to get that first dorsal lateral plate as far lateral as possible. That really sets up two things. One, it sets up a biomechanical advantage to continue to close down the IM and even planar flex the first ray and keep that alignment on the sagittal and transverse plane. But as important or more important, it allows you really to get the biplanar plating and allow that medial plate to go at 90 degrees. We'll talk about the insertion of this and then the energization of the plate where we take off the inserter cap, and we'll go through this. So, Aaron, this is kind of what you're talking about. This is the feather rasp. This is the, the center of the joint marker. We'll play this video and we'll kind of talk through it. But basically, Lapiplasty, exactly as you always would. We're going to do our instrumentation for that consistency. We're going to do 2 or 3 points of fixation. We often added a third point with the speed plates because all 4 tines have to go in at the same time. Aaron, do you typically do, this is showing a 3-wire kind of stabilization and construct. Do you do 3-wire, 2-wire, wait till you hit 1, throw it a third? Like, how do you typically do it?
Yeah, so I was just going to comment that looking at that picture there, it literally could look like all the surgeons who are doing Lapiplasty say correctly or have done so many of them. This is exactly what my construct probably looks like. I have the fulcrum. It may or may not use the olive wire. I am pinning, distal lateral to proximal medial, and then I also run another wire. I've been running them actually crossing screw technique. I used to do the M1, M2, and I stopped doing that because I started to feel I was getting a little bit more elevatus. I wasn't sure if I was pinning it correctly, so I've kind of stopped doing that. But I definitely feel that these 2 pins, sometimes a third if you feel like it's necessary, but I've gone to just the 2 wires crossing like that, and then the 3rd wire, of course, to go across and pin the, but if you do it through the compressor, it's a lot better because at least then it's straight across, as opposed to I was doing it separately, you know, from M1 to M2. But this is almost exactly how I do it. And then once you get that set, you can pretty much hands free everything and then just deal with your fixation.
Yep, absolutely. So we'll play this video. So this is a technique where there is a tack just being placed in your intercuneiform joint. We'll talk about this in a minute. That's that step off. The bottom of the guide mimics the plate. So if there's any teetering, this has to be taken down. And just like Aaron said, this is the feather rasp. So the feather rasp comes in, it smooths that dorsal surface, and then you're setting up your plate. So Aaron, that's a kind of a trick or technique, if you will, putting that pin into the intercuneiform joint in order to ensure you're as far dorsal lateral as possible. Do you do anything different? How do you ensure that you're far enough lateral and not midline on that?
Honestly, I love that little idea you threw in there right there, because honestly, I have not used that technique, which to me is, you know, a lot of it is just kind of knowing just anatomy wise. I kind of feel like I've been able to kind of place that directly where I feel like it should sit. And for me, that little wire trick is a great idea. But for me, it's just kind of knowing exactly where that's located. I kind of check with X-ray once I pin it, but I guess it's kind of a feel thing sometimes. But I feel like once you get it, you kind of know where it's supposed to sit, and that's exactly where it should go every time.
Yep.
But I like that wire trick.
Yep, good point. So once this is placed over, there are drill tacks, and they go to the laser line, and then there's a rescue drill. You just want to talk about these tacks, Aaron, real quick. These are the outer tines, and what are they used for?
So if you use the drill tacks, you can see there's just a pin with partial drill, and then it's got a laser line halfway up there. So for me, you know, as I place it, you know, I'll have probably the residents kind of drill it halfway, or at least to that laser line. And then for me, at least then you can take a quick picture. So a lot of it is just a quick check before you actually buy that hole, or you burn that hole if you don't like it. So you can place it in, get it kind of where you want it. And then from there, you would bury those two other pins. And then the rescue drill, or the drill that doesn't really have the wire tips on it, is just there to go straight through. So making a point on that, sometimes you can run into a wire when you have all those wires kind of positioned across the TMT with your fixation temporarily. So if you need to, and you just don't want to use that, if all of a sudden you hit a wire with one of those drill tacks, you can kind of use the larger drill, and it should be able to slide right past that pin. But once you've kind of drilled those other holes, then you're kind of ready to go at that point.
Yep, absolutely. So we'll play this video. You can see the guide. This was feather rasp. The guide's going to go on. The outer holes are what are drilled first, just to the laser line. So as Aaron said, you're not burning a hole there. At that point, you take an X-ray, and you can make sure that you're as far lateral as possible. None of the temporary fixation is impeding into the tine holes, and you're lined up with the joint. So, you know, everything's pretty good in this regard. So, you know, Aaron, this is the picture we want to see
every time. That to me is the picture I would look at, because it kind of shades or rides the way the cuneiform down the medial or the lateral cortex of it. You know, it kind of has that position where it kind of rides down the side of the cuneiform of that intercuneiform joint, which is cool, because as long as you're not hitting into the intercuneiform joint, you're good to go.
Absolutely. And then that distal hole, you just want to make sure you have the cortical ridge or cortical rim of that first metatarsal. So, you know, this is good position and alignment. And again, as was stated earlier, being as far dorsolateral as possible with this really allows you to get that 90 construct, you know, and if you're cheated in the midline, you know, you have to go further planar with the medial plate. Sometimes that can't happen. So when we like that position, we're going to take those outer drill tacks, we're going to bury them down to the hub, and we'll show that here. And you can see that plate locked down onto the bone, you know, crossing the fixation. Then we have a 3.2 millimeter drill, and we're going to drill out the inner tines. You know, just as Aaron said, if they hit some of the temporary fixation, you're removing it or replacing it. Once all 4 tines are drilled, just like the SpeedMTP, we're going to take that guide off, and you'll see that. at this point, we're going to energize, and that inserter cap was kind of redesigned, Aaron, where you don't have to pinch it; you just slide it in. Talk to us about that new inserter cap.
So, obviously most of the time my techs will do it, but I have used it personally. But yes, it essentially, you don't, if you take the old speed plates, sometimes, so there are people that may not be able to push those down, especially the large, the larger 23s, are definitely hard to squeeze again and put the cap on. This essentially, you just find the hole, slide it all the way up, and it essentially does it for you. So it's kind of like having to not use your hand to do it. So essentially just squeezes the tines for you. And so it's all in one preset, ready to go.
Yeah, so really a great advancement to the speed plates. One of the things that is being shown here is to make sure you maintain and understand the trajectory. I'm going to watch this real quick. You can see this go in with what Aaron just talked about. So just find the hole in the bottom and simply push, and then that loads this. We're going to hand implant this as much as possible. We'll talk about this in just a minute. Then you're going to tap, tap. So one of the things, as the video started earlier, one of the things that was being demonstrated was finding all 4 holes and making sure your mind understands that angle and the trajectory of the tines. And if you're off axis, there's kind of a struggle. So you saw how that plate, the speed TMT, can just be inserted by hand. So Aaron, any tricks? Do you try to make sure, because what we don't want to do is take the mallet and create another hole or create a wider hole. So,
right.
What's your tricks? You're implanting that speed TMT. Do you try and put it in as far as possible by hand first?
Yep, about 75% normally. I mean, based upon the strength of the cortical bone that the patient has. And if you are too far lateral, sometimes if you feel like you're kind of getting into cortical bone, it may not slide in the way you want to. But I mean, if you can place it in there as far as possible, to me, it's straightforward. You're already getting kind of that compression without having to actually like hammer a new hole, or maybe you didn't drill as far in, maybe you hit one of your pins. But if you get it to where you can actually place it in there, and then you just give a couple taps, I think it's straightforward, easy as can be, without having to worry that you didn't miss any holes. Like you said, you shouldn't have to hammer this thing 14 times to get it into where it should go.
Yeah, absolutely. And this is with speed plates, speed TMT, SpeedMTP. If there's a lot of resistance, you're probably off axis, so just stop, pull that out, and then reassess it and kind of go from there. So we'll show this video in a second, but once this is implanted, you do not energize that. You do not take the inserter cap off. So just like the SpeedMTP, we're going to throw our bicortical off-axis locking screws through the plate. So Aaron, you want to talk about that drill tip and the 3 sizes of screws?
Yeah, so the picture is, you can see the gold kind of drill guides sort of in that picture. And then to me, I take the drill guide myself. I don't think it matters technically how far you drill, just based upon how these are going. But sometimes you can kind of feel if you've gone too far. But for me, I take the drill. I usually throw it into one of the, I drill both the holes. Sometimes I leave it in the proximal hole or the distal hole, just based upon how I'm working. Leave one in, take the golden retriever, if you will, and then take that out, take the screw, the drill guide, and then I'll usually choose the shorter screw for the proximal aspect, because it is kind of a different variable angle into the cuneiform, as you know, the intercuneiform joints there. And then
that's the same concept as the S4A. So the S4A had that same anatomic contour, respecting the intercuneiform joint, allowing us to put that plate as far dorsal lateral as possible. And typically we'd use that 12 millimeter. And you're saying you're adopting that same technique here.
Yes. And then I move distal, take out the drill bit, take out the gold drill guide, and then sometimes I think it's usually a 14. I mean, I can go to a 16. I guess it's just based upon the size of the metatarsal, or how we feel like we're maybe over a little more medial and we have some more room. But for me, it's probably straightforward 12 and 14, since they are locking screws.
Yep. And so the drill guide, the laser line is 12, the hub is 16. So in the center of that is 14. So you'll get a feel for that, just like Aaron said, but you do have a guide with measurement, and you can see this in action here. So once the SpeedTMT is inserted, then we're going to take that guide, go through the holes, use the golden retriever, so to speak, and take out the guides. We are using a 12 millimeter proximal. You kind of have the trajectory of the handle to put the screw in, and then we use the 16 distally. At that point, we're going to take the inserter cap off. That energizes that plate for that continuous compression. The bottom side of that is the wrench to take off the threaded towers, which is just genius. You know, that's just efficiency and real easy to do. And at this point, we're seeing our first plate. And it's important to maintain at least one, you know, sometimes two if you can, alternative points of fixation. So Aaron, you have your dorsolateral SpeedTMT inserted. It's energized. How many points of fixation do you typically still have at this stage?
I usually would have, I've probably kept, so looking at that picture, I usually have the distal lateral proximal medial pin that's still in. And then I will usually remove the other pin that you have there crossing in that picture heading towards the intercuneiform. And then a lot of times I'll just re-drill it or re-throw it. So it will be M1 to C2. So me personally, I usually have just one extra pin and then the plate.
Yeah, awesome.
Two pins in a plate, yeah.
Yep, and that maintains our rule of always 2 points of fixation. So the plate at this point acts as 1 point of fixation, and then you have a wire as your second point. If you wanted a third for good measure, you're okay to do this. The inserter cap, this is what we showed. This is just
William,
the bottom. Go ahead.
If I can make a point, what's crazy is when you had talked about, number one, you're using fast pitch screws, which is great because again, that just goes to the idea that those screws usually would allow that plate to kind of, you know, compress inward, as you've seen that video multiple times. And then the other idea is just actually showing that SpeedTMT, how it sits laterally, when before we used to throw the quad on top, and I never felt like you could get as lateral as you wanted to because it just didn't allow to sit properly. You know what I mean? So this is really a great innovation because you talked about how you don't want to put that medial plate too planar or angulated. And I felt like sometimes that the dorsal quad sometimes would cause you to do that because you just had to move it central instead of way lateral.
Yeah, no, absolutely. Great point. This is just a still shot showing the energizing the plate and then taking off the towers, you know, like we showed earlier. And then at this point, we're going to go into our medial plate for the biplanar plating. You know, the construct is surgeon's preference. We do recommend the speed plate, the micro quad. So again, Aaron, we're feathering this off. So the feather rasp, once again, this thing's just been invaluable, correct?
I totally agree with you. I use it on so many different techniques. I mean, I've been using it for ankle fusions at some point, and just shaving off anything I could find that really, because it's great. It uses, you know, it's fast. I love that you can hook it up to power. So to me, it's been truly a gift because again, the hardest thing by trying to shave off the medial side of this first metatarsal, you take too much. Now you lost cortical bone. Your plates aren't going to sit right. It's going to not look great on X-ray. And now you can really get this feathered down to where you want it to be.
So we'll show this. So this is the feather rasp. I think it's important that we don't create a ledge. So you see how this is going planar, medial, and planar. So you're not creating the ledge. So you're rounding that off. And then this is our micro quad. The half pins are going to go in the outer side. We're going to confirm we're at 90 degrees in a 90-90 construct. And then we're going to drill this. Again, this is the energizing of the speed plate without the new top hat. Ensuring where those tines are in your mind understands that trajectory, I think, is critical. We're going to hand, 70+% into the bone, and then we're going to gently tap. You can use the bottom of the inserter as a tamp. We want to try to avoid that if we can. We want to make sure the plate goes in equal. We want to make sure the bone underneath is contoured, but there is an option to kind of throw that in at that point. And so, Aaron, this is kind of what we were talking about, that if that first plate, dorsal lateral, is correct, then this biplanar construct, getting this medial, is easy. And then the other thing I want you to talk about is, you see how the feather rasp created that contour and respected the curvature of the first metatarsal, tarsal metatarsal area, and didn't create a slope. So I think it's real important to maintain that curve. You want to speak to that?
Yeah, I mean, we used to, the way we used to do it, we either just take a saw and saw it off, and sometimes you'd end up, I mean, I don't know if you've seen it, but literally you'd be taking a small slip of the anterior tibialis tendon, which never really made me feel good when I would take off that slip of that first metatarsal. So now I don't really have to worry about it, but I can actually contour it to actually stay more rounded. Everything more rounded in the foot is probably better than squared off. So, we used to square things off. Now we can kind of keep it rounded. Most of the plates we're using have a contoured, rounded, or curved shape. So for me, it's easy to get that shape exactly how you want.
Yeah, and then the biplanar being at 90 construct, we've proven that time and time again. So super important. And then you kind of see the final construct. You can see the clinical and radiographic, alignment of this. And I think what's really important is look at the clinical, how well that SpeedTMT sucks down and adheres the bone. There's no gap over that center bridge and the underlying bone. And I really believe a lot of that's due to the addition of the off-axis bicortical screws.
I agree with you. And just looking at that medial microquad, that is so thin, small, that I barely see anyone have an anterior tibialis rubbing pain. I mean, you used to put bigger, bulkier things in there, and there was always that irritation. But these have been great to not have to worry about that afterwards.
Yeah, that's a really good point, actually. Because the micro quad allows 2 points of fixation on either side, so you're still adhering to the rules of fixation and crossing a joint. Because it's not as long, you're really not impeding at all that tibialis anterior insertion.
Right. Yeah.
So we're going to go through some cases. And Aaron, one of the things that's unique and very beneficial to Treace and everything that was created with the reproducibility, the instrumentation is whatnot, is a lot of these just start to look the same. So, you're seeing here, you have a, metatarsal primus varus. So instability of that medial column and first ray. And then we're implementing the speed TMT. So as we see this first case, you can get complete anatomic reduction and whatnot. What you're seeing is a intercuneiform screw, an M1, the C2, and kind of addressing that intercuneiform instability, or sometimes that's just your construct. So Aaron, talk to us about that screw. Do you use that routinely? Do you test for it intraoperatively? Is it part of your normal construct? How do you view this?
Yeah, when I first started, I did the C1, C2, and I lost a little bit of rotation, and it only takes one mishap for me to decide that I'm going to switch up my my protocol. So from there, I went to the M1, C2 as kind of a safety net for me, because I want to make sure my IM angle is shut down appropriately. But normally I will do a stress view in between the great toe and the second toe. You can kind of squeeze the metatarsals distally. You can kind of watch it on fluoroscopy live and see if there's a splay test or some form of opening or gapping. And at that point, that's when I normally am going to throw that in. But I would say 90% of the time I'm throwing this screw. For me, it's a benefit. I feel like I want to keep that IM angle from reopening of any sort of any instability, which probably happens through the Lisfranc's area. So for me, I'm always kind of throwing that screw.
Yeah, I think it's a great point. Fleming published an article showing that once the first tarsal metatarsal joint is stabilized, there's 74% intercuneiform instability. I love what you said about that kind of, safety net, so to speak. One of the things that's important, this is a fully threaded screw, so it's a positional screw. This is not a lag screw. So all your correction came from the system, from the Lapiplasty system with the positioner and the cut guides and whatnot. and then the biplanar plating holds that there, and then this is an additional point of stability across that intercuneiform joint, which I completely agree with you. This is part of my normal construct, at this point, but it is a fully threaded screw. So as we go through case, go ahead, Aaron.
William, real quick, William, the big thing is that you're essentially taking that fusion site that you've put together with the construct, and you're essentially just moving that entire construct from medial to lateral to keep it in place. So you're right, it's not there for compression, for me.
Yeah, no, absolutely. And you can kind of see, the case 2, it's wash, rinse, and repeat. Now I wouldn't know that because I don't have much hair, but Aaron, you could probably speak to wash, rinse, and repeat.
Right, for sure.
So you understand that this just continues to be consistent. And we see this, time and time again with the outcome. And we really want to highlight the plate and the, just the overall, shape of this. So Aaron, in this case, there's an Aiken osteotomy, and this is with our Speed Aiken. Is this something that you do routinely? How do you look at Aiken osteotomies for these corrections?
Yeah, for a while I did, and we used to always talk together and say, hey, if the great toe is touching the second toe, better do an Aiken. If your lateral release wasn't quite there, add the Aiken. If you didn't quite get it, or if there was some sort of rigidity, or you just couldn't get the sesamoids over. So now there's probably at least 80% of the time I'm doing an Aiken. I don't want it to deform the thing, so I don't want it to look kind of a weird Aiken. So I love that we have the ability to do small, speed Aiken plates. I will use screws that we have, different screws. We have bevels, super bites that we can use, that I do it as a minimal invasive technique, but I am doing Aikens probably more than I used to. That's for sure.
Yeah, same. I really think the Akenator has been a game changer for me. I love that saw blade. That creates that wedge instantly. And then these Speed Aikens have been tremendous. I mean, the stability across that fusion site has just been really good, in my hands. And you continue to see these constructs, the addition of the M1C2 screw for, additional stabilization, the Aiken osteotomy, and you can see complete reduction for this. This is a case, Aaron, this is, Dr. Dag, Justin Dag, again, he's operating currently, but, this is where he used this for a, Lisfranc's injury. So he has kind of his Lisfranc screw, the traditional home run screw, but he also chose to fuse the second tarsal metatarsal joint, and he used the Speed TMT. This is really universal. You can put this plate anywhere that it fits, basically, in foot and ankle surgery.
Yeah, if it's got the size it can fit and the bone that can handle, I mean, it's streamlined. It fits pretty much great across that midfoot for me.
Yeah,
so,
and you really see that contour down. I think that's great in regards to the fixation. Now, Dr. Dag's not here, so he probably should have locked that screw proximal a little more. So we'll give him some slack for that, right? He's not here to defend himself. So just for the viewers at home, make sure you do 1 or 2 more turns on that proximal screw. So
when you put them in, you can start squeaking that thing, until it stops.
Squeak it till it stops. There you go.
No.
You heard it first from Aaron Chokan. This is another Dr. Dag case, and this is where he did a 3-2-1. And sometimes the stability when you add that second, third tarsal metatarsal joint is really good. And so he chose to just make that Speed TMT plate a singular and put it a little more medial, and then still have his M1C2 screw. And Aaron, I guess the takeaway on that is really about stability. If you feel you have enough stability and this plate performs very well, at times this may be an option for you to do.
Sure, for sure. If he felt he's got, with C1 or 2 and 3 already fused, the stability is really there. And as long as you have that M1C2 screw to just hold that first ray in place, I think if you feel like you have enough compression from just the dorsal plate being long enough to grab down far enough, and you felt like the compression was there, I'm sure you could go one plate only on there.
Yeah, no, absolutely. So, and this is another Dr. Dag case, and you can see this reduction. He chose here to do the Aiken, not the intercuneiform. And again, it all comes down to the stability, that mechanical versus functional instability when you do the splay test. And it's really surgeon's preference as to whether you need it or not. But I think, when you look at that lateral, just look how that a SpeedTMT hugs down to that dorsal cortex of bone. There is no daylight between that plate and the dorsal cortices. And
No,
I really
and
think
even the AP, even the AP, look how nice and curved that really runs, kind of that whole angle there, really.
Yeah, and respecting that morphology of that lateral cortex of the TMT. Now, it's a great point. And, again, super excited, about this because, these are what we're seeing. So this is a revision. So you kind of see the anatomic quad in the top left. This went on to a non-union. Multitude of reasons why this may or may not happen. But when you have that non-union and that kind of micro motion, you can see that anatomic quad kind of dislocating or migrating dorsally. Mm-hmm. So, with the addition of these screws, we really think that's going to lock that down and prevent that from happening. But so, Aaron, you kind of talked earlier in regards to revision. This probably didn't need a graft, to extend this out. But, this plate for revision surgery is a great option. You want to?
For sure. You can put graft, you just same with the SpeedMTP, similar. You can have enough span to put a graft there just because, and again, it was always difficult with just a regular plate. You'd almost run into a problem because it would never span far enough, and you'd have a difficulty trying to find screws to place those holes, especially if you had to remove so much bone. So now with this, they're spaced out so far that you can still get a graft in there and still get the 4 to 6 points of compression across it.
Yeah, and I also personally haven't had an issue, adding this plate. So there's an anatomic quad, and then this surgeon chose to put the Speed TMT over top of that. And, it's finding new bone, the addition of those screws to lock down the plate. I don't see an issue with this at all. I mean, any apprehension, putting in another 4 tine?
No, I don't think that would be an issue. I mean, you can move it a millimeter here and there and still find brand new bone, let alone that looks like it was slightly more lateral and this one just looks slightly more medial. So they probably missed it just by, millimeters of miss and still got what they needed.
Yeah, it's a great point. No matter what you did, you're going to have to put plates and/or screws anyway. So you're going to fill those holes one way or the other. So, in conclusion, this is an advancement of our biplanar plating system. We're super excited about this. This dovetails literally off of the success of the SpeedMTP, and that plate has just been outstanding. So now with the addition of the bicortical off-axis locking screws and extrapolating that technology proximal to the TMT, we're really excited about this. So, as a fixation option, it's an all-comer biplanar plating. Really think it's going to help out with revision surgery, male patients, kind of with that larger foot and that lever arm. So, Aaron, you had mentioned that the first case that you did, and you claim it's the first in the country, was a 17-year-old female patient. Are you primarily looking at this as your biplanar construct for your new dorsal lateral plate? Are you looking at this as a male, bigger foot? How do you look at this?
I look at this as now, if I can use it as much as possible based upon availability, I will go with this first. I think it just gives way better compression. I feel comfortable using it now every time. I don't have any issues or concerns about how it's going to fit. I still think it fits great. And for me, it's, again, fast efficiency is the way I want to do surgery. So for me, placing it in, getting it where I want it, and then throwing a medial plate, knowing that it's gone so far lateral and rides that cortex that I know that I'm going to be far enough lateral that I know I'm not going to have to angle that medial one 45 degrees when I know I can get it straight 90. So for me, I've been using this more often than not.
Yeah, I agree. I mean, it's the same as the SpeedMTP, super excited about the patient outcomes with that. And again, we recently presented that at ACFAS. That's going to be followed up with a paper that we're going to submit for publications. That poster actually took those patients out to 6 months, and we're going to publish on the 1-year data. What's interesting about it is we think that same success is going to be mimicked or mirrored with this Speed TMT plate. So, you know, we left 10 minutes for questions because Aaron and I are trained professionals. So we brought it right, you know, wire to wire. So if there's any questions in regard to the new Speed TMT or anything about Lapiplasty, the fixation, the reduction, the instrumentation, you know, anything at all, Aaron and I are happy to help out.
Yeah, thank you, Dr. DeCarbo, Dr. Chokan. Sorry that Dr. Dag wasn't able to make it. His case is going a little bit late here. So yeah, if you have any comments or questions, please feel free to type those into the chat. We can hit on those here in the next few minutes. And while we're waiting, just once again, thank you to both of you for sharing this experience. And, you know, I can confirm that Dr. Chokan's was in fact the first of these cases in the country.
I want to see the tape.
It's been really exciting.
It's been very exciting. I think
it.
I only got lucky by someone's case got canceled, but that's just how things happen, you know.
Or snow, or you know, something allegedly happening. Who knows? Yeah, but no, this has been a really exciting addition to our portfolio. Obviously, we've, you know, here internally been really excited for it. As you mentioned, Dr. DeCarbo, the SpeedMTP just has completely, you know, revolutionized fixation, you know, in our minds and in the minds of you guys as faculty. So being able to bring that technology and that concept to the TMT and Lapiplasty has been really exciting, and we're even more excited to see where it can take us, you know, moving forward.
Yeah. So
and
Lauren,
one thing.
Yeah, go ahead. No, go ahead. I didn't mean to cut you off. I thought you were done.
I was just gonna. I'm never done. One thing we always like to plug on these at the end is the availability of peer-to-peer interactions with you guys as our faculty, as our design surgeons, as our absolute, you know, experts in our products and procedures. And if any of you on the line have not taken advantage of one of those, please do so. You know, it can be, hey, I have this case coming up, you know, what would you recommend? Or just let's talk through it together. You know, Dr. DeCarbo, maybe speak a little bit to the efficacy or just what those peer-to-peers do. And we're not talking just Speed TMT here. We're talking everything, right?
Yeah, absolutely. You know, the idea of the peer-to-peer review was that we, as a company and as a philosophical standpoint, we didn't want to say, hey, here's a technique, here's some hardware, have at it. We want to really make sure that the success of the surgeon is reached, because if the success of the surgeon is reached, then the success of the patient, which is all of our goals, is reached. And so this is a way to kind of brainstorm, you know, talk over ideas and talk over potential rough spots or trouble spots within a specific case or within a specific technique, or an outcome maybe that didn't go quite the way that was expected, and you can kind of talk through it. And what we've found is in those open discussions, sharing x-ray, sharing conversation, you can always add one or two things that, you know, sometimes the surgeon just puts it back in their mind and refreshes it, that they're like, yeah, that's a, you know, very good point. I'll keep that in mind and, you know, think of that next time. And it's those little things that kind of make the big difference. You know, that's everything in life, you know. So that peer-to-peer really allows you that kind of one-on-one, just talking, brainstorming, you know, and that has been a mainstay for us. The other thing that I was going to say earlier, and Lauren, you could talk about this, you know, all the plating of speed plate options, you know, all the you know, traditional or OG plates, if you will, and specifically these SpeedTMT, with the addition of the screws. There's going to be upcoming webinars where we're going to use this at other locations. So, you kind of showed in this a little teaser in regards to putting this over the second TMT, but we have surgeons, Lauren, you can speak to this, an upcoming webinar that really use this for calcaneal cuboid, talonavicular, navicular cuneiform. So it's really anywhere that you need, compression plating, and that kind of fits the anatomic area.
Yeah, exactly. It very multi-purpose, and based on once again the success that we saw of this combined technology with SpeedMTP, bringing it to TMT, and then expanding it, looking at expanding it further. So a little bit of a teaser there into the portfolio as well. So I'll kind of leave it at that. And earlier on when you were talking technique, had a comment come in, just a little tip that he likes to do intraoperatively is, use a little skin marker pin maybe on the drill to see where the holes are to make implanting. I know we've talked about that in the past, so that also came up as well. So just wanted to hit on and share that little tidbit that came through as well. So when you're trying to find your holes to insert the implant as well.
Yeah, so it's a great point. And so, what that surgeon is talking about is taking the skin marker and literally just coloring the tip of the drill. And then as that goes down and makes that implant, it'll leave behind that residue, so to speak, and you can kind of see that drill highlighted. One of the things that I've done in there, and I'd love to hear your take on this, is after I do the 4-tine drill, and then I pull that off, I'll take a half pin and kind of find each of those holes. But a lot of time I'll take the marker and stick the point of the marker in each hole, and that will create that stain on the skin, marking that. So it shows up like a black eye, so yeah. It's kind of a neat technique. You doing anything different or anything otherwise to make sure you find the correct hole in the trajectory?
A lot of times I'm just kind of like maybe placing a pin in more distal and proximal, just to kind of keep those two, the ones that probably are more harder to find if my skin incision is just not as large and I'm kind of having to move some soft tissue out of the way. But once I kind of get those two lined up, that's kind of where I'm just going forward instead of having to mark everything. But yeah, somehow just to get something where I get started.
Yeah, so all great techniques and all great little, tips and pearls. The overarching takeaway is just make sure you're following the same trajectory. If there's any resistance, just stop, and then
don't feel like you get a mallet for days. It shouldn't be that difficult.
Yeah, no, good point.
Yeah, thank you guys. So nothing else so far. If anyone on the line thinks of anything, please reach out to your local representative, reach out to the medical education team, the product management team here at Treace. We're happy to answer
Lauren,
anything,
did you see these
to put you
questions?
in contact with anyone. Yes.
Did you see these two other questions? Oh, okay. All right.
Yes. Thank you. So yeah, we are always available to you as a resource, and always want to make sure that you are connected with your peers, with the experts in our products and procedures. We have a number of medical education events, hands-on cadaveric events happening throughout the rest of the year. So once again, reach out to your local representative, medical education, product management, etc. As mentioned, we appreciate you spending this evening with us. Once again, if it's not, if you can't tell, by Doctors DeCarbo and Chokan, we're very excited about this addition to our product line as a really nice, very robust option for the Speed Plate line. We are very excited about it, and excited for you to try it and give us your feedback as well. Dr. Chokan, Dr. DeCarbo, thank you so much, as always, for being here this evening. Appreciate you. And we look forward to the next one.
Yeah, thanks, guys. Thanks you all for joining, and look forward to hearing your results with the new SpeedTMT.
Awesome.
Thank you. Have a good night.
Take care.
Take care.